A man aged 56 years, recently returned from work in central Queensland, presented to the emergency department of the Gold Coast University Hospital in Queensland, Australia, complaining of 36 hours of severe headache, photophobia, nausea, vomiting and neck stiffness. On examination, his Glasgow Coma Scale score was 14. He was febrile, 38.5 degrees centigrade, photophobic, and neck stiffness was objectively evident. The patient had a history of significant exposure to untreated fresh water. He had recently performed physical work on a property in central Queensland and had swum on 2 separate occasions, in stagnant water that was also accessed by cattle. According to his family, he had a habit of irrigating his nostrils in the shower after work, which he had most recently done in the days preceding his presentation to hospital. Water used to irrigate his nose was untreated bore water. A spinal tap was performed and a sample of cerebrospinal fluid was sent to the lab. Now take a look at the results. The patient was empirically started on ceftriaxone, benzylpenicillin, and dexamethasone. Over the subsequent 2 hours a decline in Glasgow Coma Scale score to 10, eye-opening 2, verbal response 2, motor response 6, necessitated admission to the intensive care unit. Initial brain CT was normal. Now what do you think the cerebrospinal fluid wet mount microscopy would look like? What does he have? Think about it for a few seconds. We'll talk about the answer in just a bit. Wet mount microscopy identified free-living amoeba, and diagnosis of primary amoebic meningoencephalitis was made within hours of presentation to the emergency department. Multiplex polymerase chain reaction identified Naegleria species. The patient was electively taken to theater for insertion of a ventriculostomy drain to allow intrathecal administration of amphotericin. Treatment consisted of intrathecal amphotericin 1.5 mg daily, amphotericin 50 mg intravenously every 12 hours, rifampicin 600 mg intravenously daily, azithromycin 500 mg intravenously daily, fluconazole 800 mg intravenously daily, dexamethasone 8 mg twice daily and chlorpromazine 50 mg intravenously every 4 hours. On day 2 after ICU admission, the patient demonstrated profound and maintained sympathetic nervous system activation, with heart rate greater than 150 beats per minute, systolic blood pressure greater than 180 and respiratory rate greater than 40 breaths per minute. Brain CT results remained unchanged from admission images. Echocardiography showed a vigorous heart, electroencephalogram ruled out status epilepticus and his vital signs showed no response to fluid and electrolyte replacement, adenosine, analgesia, or sedation. Despite early aggressive management, the patient had bilateral fixed and dilated pupils on day 3 of his ICU admission. Further CT imaging demonstrated extensive edema in the frontal, temporal, and occipital lobes, global sulci effacement and posterior fossa mass effect. After discussion with the family regarding clinical progression of disease, the decision was made to withdraw treatment and provide palliation, and the patient died within 72 hours of presentation. Naegleria fowleri is a free-living amoeba typically inhabiting warm bodies of fresh water and soil. It was first linked as the causative organism to primary amoebic meningoencephalitis in 1965 by Australian pathologists Fowler and Carter. Epidemiological studies reveal PAM typically affects young males exposed to warm bodies of fresh water. A review of 111 cases of PAM occurring in the USA between 1962 and 2008 found the average length of time from exposure to onset of symptoms for these cases was 5 days. The average length of time from onset of symptoms until death was 5.3 days and average length of time from exposure to death was 9.9 days. Upon exposure to contaminated water, A person is infected by migration of Naegleria fowleri across the nasal mucosa and via the cribriform plate to the olfactory bulbs. From there the organism gains access to the brain parenchyma, causing a necrotizing meningoencephalitis. Effective treatment remains elusive and the case fatality rate approaches 98%. The mainstay of treatment has been amphotericin B, intravenously and sometimes intrathecally. Due to its rare and rapidly progressive nature, and the need for a high index of suspicion, PAM will likely continue to result in high mortality. A high index of suspicion and early involvement of infectious disease specialists and microbiologists are required so that rapid, aggressive intravenous and intrathecal therapy are possible. This was the article that this video was based on. Some small changes were made so that viewers could guess the final diagnosis.